So good afternoon, everyone. My name is Dr. Stephanie Plamondon, and I am a physical medicine rehabilitation specialist. So that's a physician in the specialty of physical medicine rehabilitation or physiatry, and I'm here to give you an overview of neuromuscular diseases. I work in the Neuromuscular Clinic at the South Health Campus in Calgary with a team, and this is the South Health Campus here in this picture. So I think I'm going to start by answering some questions that patients often have when I first meet them, and that is, what is a physiatrist? And sometimes it's easier to say what a physiatrist is not to describe things. So sometimes we get mixed up with physiotherapists, and other times podiatrist or foot doctor. And then the other one that's common even in the hospital is psychiatrist. So we're not mental health experts, not foot experts, although we see patients with foot pain sometimes. And we're not physiotherapists. We don't deliver the therapy, but we are physicians that work in rehab. Another name for us is a physiatrist, and in the States it's pronounced Physiatrist. And around the world, in some places, it's called or referred to as rehabilitation medicine. Not, again, to be confused with addiction medicine. Our group of physicians are nerve, muscle, brain, and bone experts that treat injury or illness non-surgically to decrease pain and restore maximum function. So today, what I'd like to cover is a little bit of anatomy on the types of neuromuscular diseases as well, and try to explain a little bit about how we move, what fatigue is and what can cause it, in what ways neuromuscular diseases affect patients in their daily function and quality of life, and what the benefits and risks of exercising with a neuromuscular condition can be. In terms of neuromuscular disorders, there's a large range and variety. There's over 600 different diseases. They're a large group of often progressive diseases that can impact independence and quality of life, and the Muscular Dystrophy Association indicates that there are over 50,000 people living with neuromuscular conditions in Canada. So they're varied in that they affect different parts of the neuromuscular system, from the anterior horn cell, which is in the spinal cord, through the peripheral nerves to the neuromuscular junction and the muscle. And so there's a variety of diseases and types of problems that can happen depending on what part of that nervous system is involved. But for the most part, weakness, sensation loss, pain, contractures, and fatigue are pretty common symptoms. There are also diseases that can affect other systems outside the neuromuscular system, such as the heart and cardiac system, or the lungs and the respiratory system. So to start with the anatomy a little bit, to give you a picture, which is always easier, this is an image from the Stanford Neuromuscular Program. And this is just showing the brain, the spinal cord, and the peripheral nerves coming out from the spinal cord into the arms and into the trunk. If you're thinking about starting to make a movement, the original impulse or thought originates in the brain. This activates the motor system and sends impulses down through the spinal cord. And if you were trying to move your arm, for example, the signals would come out from the neck and into the arm, and depending which muscles were being trying to be activated, say your hand, certain nerves would be the ones sending the impulses down. So in the hand, it's usually the ulnar nerve or the median nerve or the radial nerve, depending on which movements you're trying to do. If you're trying to activate your lungs and the breathing muscles in the chest, you would be sending the impulse out from between the vertebrae in the thoracic spine or the trunk. And the nerves would come out in between each of the vertebrae into the trunk. And then if you're trying to activate your leg muscles to move, the impulse has to go all the way down through the spinal cord and come out in the low back between the vertebrae and travel down into the legs. So this picture just illustrates different types of nerve cells. So at the really low level, we have a nerve cell with the cell body. It's kind of like the control center for the nerve cell. And it can send impulses down the axons or the cables of the nerve to its next end organ or another nerve. This outer coating is called the myelin sheath, and that is present on some nerves, but not all nerves, depending on how fast the signal needs to travel. So for a nerve going to a muscle, we need it to travel really quickly to have a good reaction speed when we want to move really fast. So the myelin sheath acts as an insulator and allows that signal to travel down really quickly. And you can see the difference between these two pictures. This is an unmyelinated nerve, and so this signal comes down a lot slower than it would with a myelin coating. An example of a nerve where there is no myelin or little myelin would be the nerves that tell us about pain and where it's located from the skin. So those nerves don't send the signals as fast as what we need for controlling muscle movement. And then the picture on the right side just shows a little bit more, from the first picture, the yellow is the peripheral nerve that's traveling down into the arm and giving off little branches to different muscles along the way. And along with the nerve, there is a blood supply. Your blood vessels and your arteries and your veins travel along with those nerves and supply them with a blood supply as well. There are many, many different types of nerve diseases, and we can classify them in different ways, but one way is to classify them as to whether they are hereditary or genetic causes versus acquired later in life for other reasons. So an example of a hereditary condition of a nerve disease is Charcot-Marie tooth disease. Another name for it is hereditary sensory and motor neuropathy. So there are subclassifications of that as well, depending on whether the nerves affected by that genetic condition are the outer myelin sheath is the problem or the cable of the nerve is the problem, and whether there's mainly an effect on the nerves that supply feeling and sensation versus the nerves that supply the muscles, so the motor nerves. So there can be a combination of the two, or there can be just one or just the other affected. Spinal muscular atrophy is a purely motor neuron disease, so it doesn't have any sensory problems or affect the sensory nerves, but it does affect the motor nerves that supply muscle. And then there are hereditary forms of ALS. Another name for it is Lou Gehrig's disease. But again, that's a motor neuron disease that's only affecting the nerves that supply the muscles. In terms of the acquired types of nerve diseases, we can also divide them up into the different underlying causes. So there can be traumatic causes from an accident, whether it's a local injury to a specific nerve, like a knife wound or a gunshot wound, or whether it's a stretch injury, for example, in, say, a car accident or a motorcycle accident, where the nerves are stretched that go to the arm, depending on how the injury occurred. And then there's degenerative causes like osteoarthritis or a degenerated disc that's pinching on a nerve coming out from the neck or the back. And then there are systemic causes like different diseases such as diabetes that can make those nerves not function properly because of the associated problems from the diabetes. Other toxic causes would be things like alcohol or certain drugs and chemotherapy agents that can also damage the nerves. And lastly, inflammatory and infection causes as well are under that category of acquired. So when we think again about the anatomy, if we think about particularly the motor system, how we want to move, we think of that voluntarily in the brain, send the signal down through the spinal cord, through the peripheral nerves. And there is a point at which the nerve attaches or communicates with a muscle called the neuromuscular junction. And if you look at this at really low levels, say under a microscope, high-powered microscope, this is the end of the nerve ending, and this is the muscle membrane, muscle cell membrane. And there is a little space in between there where there is a chemical reaction that occurs and receptors. So if there's any problem or disease of the receptors or at this level, it's referred to as a neuromuscular junction disorder. And a common a common neuromuscular junction disease is myasthenia gravis, as an example. Then if we move on to thinking a bit more about muscle anatomy, once we have a normal peripheral nerve, normal neuromuscular junction, there are a number of muscle diseases that can cause weakness and fatigue and decreased independence and mobility. So how does a muscle work? So in terms of the anatomy of a muscle, we can see at this end here, this would be a tendon attaching to the bone at one end, and at the other end there would be, again, a tendon or connective tissue attaching to another part of the bone. And in order for us to move a joint through a range of motion, we have to get that muscle to contract and shorten. And if we want it to sort of open up that joint, you would be contracting and letting that muscle lengthen. So the muscle is very much organized into groups of fascicles by connective tissue support. So the outer connective tissue is referred to as the epimysium, and there's different layers in between with smaller groups of muscle fibers called the perimysium and endomysium surrounding those groups of muscle fibers and fascicles. And at the smallest level, one muscle fiber, the outer membrane is called the sarcolemma. If you look down even farther at one muscle fiber, there are two different proteins called actin and myosin filaments, and they take ATP, the basic energy of the body, and use that energy to form cross bridges and link together and slide across one another to contract the muscle. So different types of contractions you may have heard of before include isometric contraction, where there's no movement at all, and that means equal length, so the muscle is not shortening or lengthening, and that's when you just contract the muscle and activate it, but you don't have movement of that joint, or the limb doesn't move. Concentric contraction refers to when you're lifting that weight and shortening the bicep muscle, for example at the elbow, and flexing the elbow. That muscle is shortening and the filaments in the individual muscle fibers are sliding across each other to shorten. And then eccentric contraction is when we are lengthening to control lowering the rate. It's kind of the control type of contraction. And it lengthens the muscle, allows the filaments to slide again across and release, and lengthen the muscle so that you can slowly let down a weight, for an example there in the picture. So within muscle diseases as well, we can kind of divide things up into hereditary and acquired also, just as we did with the nerve diseases. So examples of different types of hereditary muscle diseases would include a large group called the dystrophic myopathies, and examples again of that would be things like Duchenne's muscular dystrophy or Becker's muscular dystrophy, which are progressive diseases that affect a protein in the muscle membrane caused by a genetic problem. And so those are an example of hereditary type of muscle disease versus, again, these different categories of acquired types of muscle disease like inflammatory, toxic causes, endocrine causes, infection causes, and associated with other diseases like systemic causes. So examples of associated with other diseases might be things like different rheumatological diseases or autoimmune diseases, where muscle disease is part of that bigger picture affecting multiple systems. Inflammatory example would be something called polymyositis, where again there's this autoimmune response that's responsible for the disease and causing the muscle to be weak and inflamed, and so the treatment for that partly is immune suppressing medications. So in terms of day-to-day functioning, it can be quite varied patient to patient how and when different day-to-day functions can be affected by the symptoms that they get from the neuromuscular condition. But mobility is a very obvious one, right? So stairs, walking, running, getting up and down from the seated position, transferring, getting in and out of the bathtub, those sorts of things. And then self-care activities, so just dressing, bathing, those basic day-to-day things that we need to do, we refer to as activities of daily living, or ADLs is our little short form for that. Some patients depending on the diagnosis, will develop swallowing problems and have problems with getting enough nutrition because of those swallowing issues, but there may be other reasons for poor nutrition. And then work, school, or getting around the community, being able to drive or use public transit can be a problem for some people. And lastly on the list, I've added sexual health. There is very little literature to date on how sexual health is affected with neuromuscular conditions, but there's a little bit of literature, and there's a lot more on areas such as spinal cord injury and stroke. But in our own clinic, we've done some recent surveys, and there is a small number of patients who feel that it is an important part of their function that's affected, and that require some assistance with that. And some of the potential things that could be an issue in this area would be the weakness or the pain that may be affecting sexual function, but also body image and interpersonal relationships, especially in those kids that developed with congenital or other types of muscular dystrophies early on that were a part of their development. And neuropathies can have a direct effect on sexual function because of the nerves that innervate the different sexual organs as well. For example, in diabetes, that can be affected, particularly in terms of erectile dysfunction, because of the nerve supply to the sexual organs. So our team is quite varied to try to help deal with a lot of these different issues of problems in function due to the neuromuscular condition. And so we have available to us here at the South Island campus all of these specialists in allied health. And our aim is really wellness. So we wanted to try to improve and maintain quality of life in neuromuscular disease patients. And so our role really is to try and to educate. Hopefully we're doing some of that today and in the next few weeks in particular, to monitor the disease when patients come to clinic, and to intervene when necessary when there's rehabilitation and medical treatments available for those issues. And again, patients and families to local resources. We don't replace the family doctor, though. There's some things completely separate from the neuromuscular condition that the family doctor is qualified and more appropriate to deal with. And then the neurologist, if there's unusual neurological symptoms that don't fit with the diagnosis, then we would want the neurologist to come back in and try to help us sort that out. So how does the body make and use that energy we need to contract our muscles? There's really three different energy systems, and two of them don't rely on oxygen, as to say, and one does rely on oxygen. So the first two systems are the ATP-PC system, which is the phosphocreatine ATP system, and it's what we use for immediate energy when we're just doing a short burst, or maybe getting up from a chair, or just for the first 10 seconds or so. We use that immediate supply that's right there in our muscles, ready to go. And then if we need more energy, or there's higher intensity exercise required, we use the glycolysis system, and that's where we actually use the glucose or the carbs that we have in our blood stored in our liver or in our muscles directly, without the use of oxygen, to produce a small supply of ATP. And then the one that we rely on the most for most everyday activities and for lower intensity exercise, aerobic exercise, is the aerobic system. And that's the oxidative system, is another name for it. And that's the mitochondria in the cell that I was talking about, those little things within the muscle cell called mitochondria. They're like the batteries of the cell producing energy. They also produce water. And they use carbs, they use fats, and they use protein to make energy with oxygen. And as I mentioned, for more low to moderate and everyday activities. So sorry this got cut off a little bit when I put it on. This comes from the International Sports Sciences Association website. They have some really good visual supports. So I really like this comparison, although it cut off on one side. So just comparing aerobic to anaerobic activity. So as I mentioned, requires the presence of oxygen to be aerobic. But I think it's more using the large muscle groups reciprocally for running or swimming or walking, or using cardio machines. And it is actually the type 1 muscle fibers that are using that aerobic system. And type 2 muscle fibers are used for more anaerobic activities. So an example of a place where there's more type 1 muscle fibers would be your postural muscles, like your calf, for example. it is always working. It's always needing to support you for posture. So it has a lot of the type 1 muscle fibers because it needs to be turned on most of the time. You can't poop out really quickly or else you'd be in big trouble quickly with your posture. And so working on that aerobic system increases muscle endurance and capillary size. And if you compare it to anaerobic activities such as heavy weightlifting or hill climbing or interval training, those are activities that you would poop out really quickly. And you run out of your energy quickly because you can only use your glycolysis system so much before you need to go to the energy system that uses oxygen. So when we're prescribing exercise, we think about aerobic endurance training, we think about resistance training or anaerobic exercise. We also think about flexibility, and we think about balance training as all components. And some people maybe be able to do some and not others, or smaller amounts of some and not others. But all of those components are what we think of when we think of exercise. So what the aerobic system or aerobic training does is it has positive effects on heart circulation and skeletal muscle. It increases your ability to move oxygen. And it makes your heart more efficient by increasing the volume of blood that the heart can pump with each beat. And it lowers your resting heart rate over time. It also allows your blood vessels to be more efficient, and it increases the number of mitochondria in your muscles. It allows you to move that lactic acid out more efficiently as well. So really, in summary, what it does is it allows your body to work sub-maximally with less effort for longer, so you just become way more efficient. And strength training does something different. So strength training increases your lean body mass, it increases your protein mass, increases your force and power, and your physical functioning. And it does so by actually breaking down your muscle fibers and getting your body to rebuild them stronger and more efficiently. So it really stimulates a lot of protein turnover and increase in muscle protein, but it does cause micro injuries to the muscle, and then your body rebuilds it. So it's the overwork principle, or overload principle, that gets you stronger. In terms of flexibility, there's a few different ways you can think about flexibility as well. One is you doing the stretching yourself actively and contracting your muscle while you're stretching. Another way is for someone else to assist you with doing the stretching. A lot of people do need passive range of motion because they're unable to get full stretch or range of motion by themselves, and active assisted. And then there's balance training, which is completely separate from strengthening and from aerobic exercise, because there's a few different systems involved in balance, not just your muscles, but also your sensory nerves, knowing where your limbs are in space, your inner ear, knowing where your head is in space, knowing how fast you're moving, and your the base of your brain called the cerebellum, which coordinates movement as well. So balance training is another component that's completely separate that is important for quite a few patients that have problems with falls and may have sensory problems that would help improve their outcomes and their function. We also think about the dose of exercise. So we talked about type, but we also need to have a certain frequency and a certain duration and a certain intensity to get better, to improve those systems. So there's a little video I had at the end, hopefully, to illustrate what I mean by intensity of exercise. But in general, for duration and frequency, sometimes it can be hard when you're first starting out exercising. You want to start with a small amount and try to work your way up slowly. Or you might want to break things up, because in the literature, the goal would be, if you were able to complete 30 minutes a day, the average normal person needs 30 minutes a day, probably 4 to 5 times a week, to get the best benefit from exercise. But if you can't do that, you still get the same benefit by doing 10 minutes, 10 minutes, 10 minutes spread out through the whole day. You don't have to put it all together. You can pace yourself and spread it out. So that's another important point to make in terms of how long and frequency. It's probably 3 to 4 minimum times a week to improve, to get more progress in your cardiorespiratory fitness or your strength. So in general, physical inactivity is the 4th leading risk factor for death from non-infectious diseases. And exercising improves blood pressure, It reduces your risk of osteoporosis or decreased bone mass. Diabetes, heart disease, depression, pain, sleep improves with exercise. So all these things are beneficial and helps prevent weight gain as well by expending calories. So what are the potential risks for neuromuscular disease patients? And I say potential because there's not actually a ton of research in this area, but what research there is suggests at the moment that highly repetitive and high resistance exercise is probably not the best idea for patients with, especially the more faster progressive neuromuscular conditions, and can cause prolonged loss of muscle strength in weak or denervated muscle. When I say denervated, I mean in the case of the nerve disease patient, where the nerve's not connected to the muscle, it's called denervated muscle. So that higher intensity, higher resistance exercise is probably more detrimental than beneficial. And high resistance eccentric exercise, that lengthening exercise, may be detrimental in some highly progressive, like the Duchenne's muscular dystrophy, those more progressive, aggressive diseases, because of the damage to muscle fibers with that type of exercise more so. With eccentric exercise, there's more of that microfiber damage than there is with concentric and isometric, especially if it's done too many times. So there's some caveats, and yet there's not great studies out there yet. There's little studies that are suggesting these things, and this is what our current understanding is. There's also in abnormal muscle a shift in the normal balance between injury and repair. So while beneficial in normal individuals, resistance training may be detrimental in some muscle diseases, so monitoring is important to make sure that the effect of what we prescribe is not detrimental and that it's advancing patients' functioning. Having said that, more and more research is coming out, and with each time I see it in paper, it's generally always positive on the exercise front. So I think on the balance of things, exercise has far more benefits than there are risks, and if we monitor and prescribe and we individualize programs to each individual patient, because patients are so different person to person, and also in the stage of their disease. We need to modify things as their stages change. Then exercise is beneficial and if prescribed properly. So what are some of the barriers that people tell me and that we know about? For some patients, heart and lung function can be a barrier depending on their disease. So for example, with Becker's or Duchenne's, sometimes heart function can be quite severely affected. Deconditioning itself with weight gain and loss of lean muscle mass is difficult to overcome at times. Pain can be a limiting or a barrier to exercising, although it can very effectively treat pain as well, exercise can. And then fatigue, just getting to a place, going to a place that's adapted for the stage that the patient is at for their condition, and time are all barriers. I think barriers to most people. Like today I was going to exercise, I didn't yet. So what is fatigue? There's actually no real medical definition of fatigue, and 18% of normal people actually complain of it as well, or about 1 in 5 people. But we can kind of divide things up into the muscle level or peripheral fatigue and central or generalized fatigue. And also motivation and pain can play a big role in people's sensation of fatigue. It's quite a subjective complaint. But we can't blame it all on the neuromuscular condition most of the time. So one of our jobs as a team and as a physician is looking for other things that are treatable or that are reversible that we can manage those symptoms of fatigue. So if someone's not sleeping well because of sleep apnea or other sleep hygiene problems, then that can really have a big impact on the sensation or the perceived feeling of fatigue during the day. If people are not eating properly and have poor nutrition, if they're already deconditioned and their muscles that are lower capacity because they weren't active to begin with, that can be a big factor in fatigue. If someone's having an infection at the time, if they're having if they have an inflammatory disease like rheumatoid arthritis or other connective tissue diseases that are associated with nerve or muscle problems, diabetes, if that's not well controlled, and anemia would be another one where if you have low red blood cells, you have less oxygen carrying capacity in your blood, you're not getting the oxygen you need to your muscles as well, then you're going to be fatigued also. And then there's the neuromuscular condition. So some of these other things we can do different things about. We need to kind of tease that out and try to manage those separately, and we can make an impact on fatigue as well. And then lastly, as a big point I wanted to make as well in terms of body mass composition. A lot of patients with neuromuscular conditions will have a very poor body composition, sort of lean muscle mass to fat mass, partly from the inability to exercise as much or be as active. And sometimes when we're monitoring people's nutritional levels, we look at BMI as a medical professional. But for BMI in a neuromuscular patient, you really have to remember that lean muscle mass weighs more than fat. So muscle weighs more than fat. So if you have less muscle mass, you might be in a normal BMI range, and yet you're actually not in a good body composition. So if you think about BMI, which is weight and height calculation, you want to be kind of on the lower end of the BMI to be healthy, as long as you're eating properly and not starving yourself. But you want to be on the lower end because if you've lost a fair amount of muscle mass from the neuromuscular condition, then you might falsely feel that you're in a normal sort of BMI range. And so waist circumference might be a better measure than BMI in neuromuscular patients. So the bottom lines are that low to moderate intensity aerobic training and strength training are felt to be safe in the neuromuscular conditions. Certain ones, the more severe ones, are probably going to be monitored to ensure that. And flexibility and balance training are also very important, separate categories. And when people think about exercise, they don't always think about that aspect of it, but flexibility is really important to maintain normal ranges of motion in the joints so that you're not having to work harder to walk or to transfer because there's a stiff joint getting in the way, or you're not fitting in the wheelchair properly because of the stiff joint. So flexibility and range of motion are very important for neuromuscular patients. And in addition, because sometimes certain muscle groups are weaker than others, and there's an imbalance across the joint, and you're more prone to developing contracture because one muscle is overpowering the other muscle. And it depends on the diagnosis and stage and severity of the disease, so that exercise prescription would change over time, likely, if you have a progressive condition. So the precautions are: don't exercise to exhaustion. Watch for signs of overwork weakness, which is like right after the exercise is done or the next few hours. You're feeling weaker and more unstable and unsteady, then you might have overdone it. So it might scale things back or pace things out. Okay. For now, avoid eccentric exercise due to the possible increased risk of muscle injury. That might change with more research, but that's the kind of common suggestion at this point. And watch for excessive muscle soreness about a day to 2 days after exercise. If that persists, then you might have done too much. You might need to adjust things a little bit. Watch for severe muscle cramping. And another one would be after exercise, if you've had an episode of dark Coca-Cola colored urine, that might be a sign that there's too much protein breakdown happening. And you would want to make sure that there's no negative effect on the kidneys, because your kidneys have to process all this protein breakdown. So episodes of Coca-Cola colored urine. And then prolonged shortness of breath, lightheadedness, or chest pain. Some conditions do have cardiac, as I mentioned, heart problems associated with it. So if there's some symptoms there that are new, then that might need to be adjusted or rechecked. And that's the end. Although I did have a little video. I don't know if I can put it. Like, you'll have to go I think. Yeah. I can't email the video, but the recorded session does have the video. Okay. So there was a little video. I'll see if I can try pulling it up. If we're not successful, then maybe we'll just go straight to questions. But I wanted to illustrate what I mean when I talk about intensity. And the videos are from YouTube. Doc Mike Evans, he's a great family doctor out of the University of Toronto. He has a whole bunch of patient-centered educational videos. And they're really good because they're just really designed to communicate well with patients. So I even looked up Dr. Mike Evans sometime. So there he is. He's got a whole bunch on exercise and back pain and things like that. And you have to just put it in the context of the neuromuscular condition as well. But
Hi, I'm Dr. Mike Evans, and today we're talking about the importance of intensity in physical activity. The stuff that gets your heart pumping. To meet Canada's physical activity guidelines, you need to do at least 150 minutes weekly of something called MVPA. So MVPA stands for moderate to vigorous physical activity. So why is this important? Well, I guess in our lives we want to invest in simple actions that improve many things. Exercise does this, from reducing heart disease or cancer to improving mental health to simply improving the quality of our lives. Now, I often get asked, what is the best exercise? And my number one answer is definitely the one you'll do. But my second answer is, when possible, do an exercise that requires more effort or that is higher intensity. The higher the intensity, the healthier the results. Why? Well, research has shown that higher intensity activities are more effective than lower intensity activities at improving our health, especially when it comes to the important stuff like reducing your risk for heart disease. But what is intensity? Well, I think intensity can be thought of as how hard a person works to do a specific activity. It's important to remember that no two people are the same, so the intensity of different forms of physical activity varies between people and depends on someone's previous exercise experience and their level of fitness. If you're inactive, any amount of physical activity can provide some health benefits. So it's best to start with smaller amounts of activity and gradually increase duration, frequency, and intensity. So how do we measure intensity? Well, we use something called a MET. So that's a metabolic equivalent. So at the high end, running might be an 8, jogging a 5, and at the bottom would be resting or watching TV, which would be anything less than 1.5. Moderate intensity physical activity, which measures 3 to 6 METs, requires effort and noticeably accelerates your heart rate. So for example, walking. Depending on your speed, the MET could range from 2.3 to 3.6. Yard work could be a 6. Housework could be 3 to 3.5, and so on. Vigorous intensity physical activity, which measures more than 6 METs, requires a large amount of effort and causes rapid breathing and a substantial increase in your heart rate. Think of sports or shoveling heavy snow. It's difficult to sustain vigorous activity for a long time. One way to think about this is to reflect on the research on athletes. So for example, cycling really hard for 30 to 60 seconds and then relaxing for the same amount of time and then repeating what we call interval training has been shown to improve performance in a shorter amount of time. The same can be true for the average person. Incorporating short periods of increased intensity into your routine can improve your fitness and decrease your risk of a long list of health complications. Still a little unclear? Let's make it even simpler. If an activity doesn't cause changes in your breathing patterns or make you sweat, then you're probably getting a low intensity workout. If you can hold a conversation but still feel out of breath, you're probably in the moderate range. If you can't talk to your neighbor or sing out loud, you're probably in the vigorous range. If you can do moderate to vigorous activity at least 150 minutes per week, you're meeting the target. So go for a brisk walk, grab a dance partner, a garden hoe, or even a vacuum cleaner and get ready. Get set and up and go. That's all for now. Thanks for listening.
So again, that was just to get an idea of what intensity means and what low, moderate, and high means. And we, in general, for most neuromuscular patients, we want to stay at that low to moderate, but it depends on the person. So you need to talk to either one of your doctors or one of your therapists to individualize your program. So, any questions?